Testing, testing. Can everybody hear me? No? Okay, good morning, everyone. Welcome to the Prostate Cafe. I'm here to answer any questions you may have. Hopefully I can. I want to thank Johnson & Johnson and Jeff, who brought with him the breakfast for this morning. They have some very interesting product lines, one of which is we call a next generation drug. For those of you who know about hormones, the primary hormonal therapy is designed and has been developed to shut down production of testosterone entirely because prostate cancer really likes testosterone. The next generation drugs, which in the case of Johnson & Johnson, it's called Erleada, also known as apalutamide, it does not shut down the testosterone production. What it does do, however, is it doesn't allow the testosterone to touch the cancer receptor. So it's a more precise kind of action for hormonal agents than the hormonal agents. And again, we call them either next generation or second line. And there's now 4 of those types of agents, which we use here. But we do like apalutamide, also known as Erleada. Anyhow, are there any questions? Yes.
I need you to introduce yourself. Who are you?
I'm Dr. Michael Dattoli.
I wrote down my question. You folks here have high quality supplements available back on the table. I would like to hear your thoughts on why supplements and how to even choose which supplement.
So she's asking about supplements. We do sell our own supplements here. Why are they even necessary? Well, I'm a big believer in supplements, and I think that as we get older, our ability to absorb vitamins and supplements goes down, and so we kind of have to keep up. Now, cancers and most diseases are promoted by inflammation. So having said that, first and foremost, we like to think of which supplements can actually reduce our body's inflammation. That's important. Diets are important too, and I'll get into that in a moment. To start out with, vitamin D3. We think that's a very important supplement. And what's very interesting about it is about 18 years ago, we learned about this relationship of vitamin D3 and prostate cancer. And it seemed very interesting that as populations who have higher levels of D3 had lower levels of prostate cancer and vice versa. Also, we came to find that at the time, 18 years ago, I already had thousands of patients, and I learned about this vitamin D3 relationship, and I subjected all my patients to vitamin D3 tests to find that the vast majority of men having prostate cancer actually had low D3s. And that was the beginning of my recommendations: get on vitamin D3. And I came to find that in some men, it was actually difficult to get their vitamin D3 to a normal range, let alone a high normal, which is where I typically like it. And since that time, when they first found these causal relationships to low vitamin D3 and high prostate cancer, there have been also some studies demonstrating that men who have already prostate cancer are at higher recurrences when their D3s are deficient. So we're very, very big on vitamin D3, and it does have anti-inflammatory properties. Some of the other agents or supplements and vitamins that do have anti-inflammatory properties, the number one is turmeric. And it's also known as curcumin or cinnamon. It's where it comes from, but we like turmeric, and that's an important one because it does have pretty powerful anti-inflammatory properties, as does resveratrol. Now, resveratrol you can get from red grapes, but I tell you, you'd have to be a wino to get the amount that you really need. Okay, so we do recommend resveratrol. Also, it's in dark chocolates, so that's a good thing. You can have some sweets there with resveratrol in the chocolate, and then there are others that we do sell here. Um, Other things that cause that affect inflammation, bring it down, would be fish oil. And it has antioxidant and anti-inflammatory properties. And I'm big on vitamins and supplements that boost our immune systems. And we do have a vitamin here. It's called Immune Support, and it has a lot of those agents that improve the immune system. And most of those are actually anti-inflammatories too. The backbone of immune support has to do with zinc, vitamin C, and D3. Those three are really big in terms of immune support. And, the thinking being is if you got cancer, your immune system failed you, okay? Because we do have, a perky immune system. And if we keep it perky, it might thwart off the cancers, from arising. But those three are very important. There's a specific supplement we recently added. It's called berberine. And it's it has an actual anti-cancer mechanism. We were using metformin, and we still use metformin. Now that's a prescription drug that's often used for diabetes, and it's cheap, and it has anti-cancer properties. But if you look at that metformin and you compare it to berberine, they're very similar. What we like about the berberine supplement is that it doesn't have the GI effect. So one of the things about metformin is that men taking it might say, kind of upset my GI system, either diarrhea or constipation or something like that, or their bowels are just erratic. So that berberine we find is an important. We're going to be adding ashwagandha into the mix because it has also some antioxidant, anti-inflammatory. It's good for sleep. It's good for relaxation, and it has some anti-cancer properties as well, and it's good for sexual function. So anyhow, that'll be our latest addition to the vitamins. And we have others, bone support, because many men who have prostate cancer also have bone metastases or are concerned about getting bone metastases. And, it keeps the health of the bone up so that the bones themselves can put up a fight. Um, with respect to vitamins and supplements, just so you can go on to Amazon, or you can go to, Walgreens or CVS, and, you look at a vitamin, oh, this one seems to have the same thing as the other one, but this one's a lot cheaper, so I'm going to buy that. But you got to be careful. And the reason why is that vitamins are not regulated at all by the FDA. And there is no obligation for the vitamin company to put 1% of the agent that they're touting on the label in that vitamin. And so that's kind of scary. And so what we do differently, and what others do specially, is to have them validated. And it costs more. And that's often the reason why vitamins are costing more money, is because they've been third party validated by places like NSF, USP, and then it becomes very important to have them packaged in a GMP certified facility. So with our vitamins, we do all of that. Okay. And so, yeah, they may be more expensive, but you know exactly what you're getting. So what it says on the label is the same as a prescription drug. It's exactly what's in the bottle. And that's not the case with many vitamins, although, I know that many other vitamin brands do have third party validation. But while we're talking about vitamins and supplements, and there are others, um, inflammation. It's just the bad guy with respect to human diseases. And so we really have to look deep to find what is causing inflammation and how could we, stop that inflammation from happening. Well, certainly red meat and pork. And I know, it tastes great and we love to have it. And so on and so forth. But those two meats do promote inflammation. And whereas fish and poultry do not appear to do that. And if you again look at population-based data, you'll find that those people who live on what we call a Mediterranean diet um, have longevity. They live longer, they get less cancers. And if you look at that, it's primarily fruits and vegetables while getting their major protein source from chicken and fish. And in fact, many of the longest lived people, those are called blue zones. If you look that up, you'll see they're mostly island nations. So they tend to eat a lot more fish, fruits and vegetables. So anyhow, those are important things. Processed foods, probably even worse than red meat and pork in terms of producing inflammation in our bodies. And so we really need to be careful of those snacks and those chips and all the stuff that tastes good, but it's often ultra processed and produces a lot of inflammation. Um, Alcohol, unfortunately, does also produce inflammation in our bodies, and so do things like cigarette smoking, which, in addition to, the nicotine and tobacco and everything, also causes a lot of inflammation in our bodies and causes other diseases too, diabetes and lung disease and heart disease, especially heart disease. There are two main um, food sources that I know of. There are many, but really powerful anti-inflammatories, and one is avocados. And I don't know if you like avocados, but we've gotten into saying, an avocado a day keeps the doctor away because they're perhaps the most nutritious food that we're aware of, today. And extra virgin olive oil, also a powerful anti-inflammatory food, and you just can't get enough of it. You can take shots instead of alcohol. Take shots of good, and it's got to be good, because you'll find out right away if you start consuming a lot of extra virgin olive oil. You'll find out the ones that are not so good, that are pretty pungent, but your taste buds won't fool you if you're actually consuming, not just putting it on, cooking with it or putting it on salads, but actually consuming directly. You'll find out which ones of the extra virgin olive oils are very good. So anyhow, yes, sir.
Doctor, your supplement prostate, okay? Well, what does that do and what are the benefits of that?
So he's asking about our supplement Prostate Health. So what we've done with that is we've made sure that every agent that we know of is in it, which relaxes smooth muscle, which is what the prostate is comprised of, as is the bladder neck, because it's all about urination. So there are things like saw palmetto, which is an item we have in it, which actually relaxes the pelvic muscles. And there are many others, Africanum pygum. And if you look at our label on, Prostate Health, it's going to have every single thing that I'm aware of, that I was able to get a company to put it all together for us in a vitamin supplement. So that's the reason why we do have the Prostate Health vitamin. Obviously, we're a prostate cancer treatment center, and even men who don't have a prostate might benefit from it because the bladder neck is a smooth striated muscle, and it's the one that gets jittery when we have to go urgently and have to go frequently, and so a lot of these agents are helpful. I may mention while I was talking about vitamins and supplements that there's an ingredient in foods, and it's in tomatoes, and it's called lycopene. And it's in uncooked tomatoes, but it really comes out in with cooked tomatoes, and it actually has anti-prostate cancer effects, and that's interesting. Okay, I mean, literally anti-prostate. It might have some other anti-cancer benefits for other cancers, but anti-prostate cancer. And lycopene, as I say, cooked tomatoes mostly, but also watermelon, rich in lycopene. Also red papaya, also red grapes, also red beets. Things that are red tend to contain this ingredient that we call lycopene. And, I would encourage you all to be on it, if you have prostate issues. Yes, sir.
I guess, and I don't know if you're going to make a presentation. I had a bunch of questions, and they're mostly about your biopsy. is the biopsy that you do as accurate as the rectal one?
Okay, so I'm here to answer any and all questions. Okay, so so anyhow, yeah. So prostate biopsies, most prostate biopsies, as this gentleman has said, are done through the rectum. Okay, so let's have you a side view. So if this is the prostate blown up a million times, okay, the rectum is behind it. Okay, and I'm going to have to get another one of these. And there's a lot around the prostate, okay, but right about here is the anus. That's again part of the rectum. Okay, the urethra runs right down the middle of the prostate, and if I've shown any of you a diagram of the prostate, I usually draw it straight down when we're looking straight on at the prostate. When in reality, if you look at a side view, the urethra actually goes something like that. Okay, it curves. Here it joins the bladder, which is like this. Here it joins the penis, okay, which is over here. And then you have the scrotal sac here. This area right here is called the perineum. There are other things around it, and here's these reservoirs, and there may be a time today I'm showing you the front side of the prostate, but this is a side view. Again, here's the prostate blown up. It's surrounded by a lot of important things. So the vast majority of prostate biopsies are done through the rectal wall. And the way you do that is you put a probe into the rectum, and through the probe jettisons out these needles. Okay, and these days we're using technologies like MRI fusion to guide our needles, but it does go through the rectal wall. Now, that's standard transrectal biopsy, and hopefully, you'll be anesthetized while that happens. But there are some pitfalls associated with it. One of which is, well, what about if the cancer is here or here? Here, that needle is not very long. Okay, and so you may have a very difficult time getting to the front side of the prostate where cancers do arise. So that many urologists will also probably do an MRI fusion, or hopefully they will, and it tells them, okay, the XYZ coordinate puts the tumor, or the target, I should say, right here, but maybe you can't get to it, and that's a problem. So geographical miss can be a problem with prostate biopsies. Secondarily, and a real big deal, is that here's the rectal wall. And let me tell you, you could do 10, small bowel enemas and cleansings and what have you until the cows come home, but you'll never ever make that rectal wall sterile. And so 100% of the time, you're going to be introducing bacteria into the prostate. Does that mean that 100% of men get infections? No. If we were in this room and you all had, COVID, except for you, would you definitely get COVID? No, but about 15% of the time you would, maybe up for the 20%. Same thing when biopsying the prostate. So you're introducing bacteria into the prostate, and about 15 to 20% of men end up in an urgent care or an emergency room within 36 to 48 hours with an infection. Most of the time, it's a urinary tract infection because the bacteria were introduced and they come up and get to the bladder. 5% of the men, though, do end up in the ICU with what we call sepsis, a bloodborne infection. So that's kind of a big deal. So that's one of the concerns when doing transrectal biopsies. The next issue at hand is, well, the rectal wall has a lot of nerves in it. So does the prostate, but the rectal wall has these really big nerves because, after all, it's the sensation that lets us know we have to have a bowel movement, and they're just loaded with nerves, and they cannot be avoided when you're doing the transrectal biopsies. You can't see them. You can't miss what you can't see. So that's a big deal because it could be very painful. Now, again, hopefully you're anesthetized during the procedure, but when you wake up, it smarts, and it's a sharp pain, as people have described it to me, and it pulsates, and it can do that for 10 to 14 days. That's very you know, uncomfortable for a long time. Finally, there's also big vessels in the rectal wall. And, you know, if you ever read about rectal cancers, you'll often read about it spreading to the lungs and liver and things like that. And that's because there are really big vessels in the rectal wall that communicate more broadly with our general circulation. So that there have been papers, reports of men who have the biopsy done through the rectum. And let's just say there's a tumor sitting here and they snip it and then come back out. But in this coming back out, it intermingles with the blood vessels in the rectal wall. And that can actually disseminate the cancer. Now, that's a really small number. It's not a large number. And, you know, if any of you have had that done, transrectal biopsy, I wouldn't be so concerned about it. But it's a real number. It's not zero, it's real. So those are the major concerns associated with transrectal prostatic biopsies, which is the most common form of doing it. And the reason it is because urologists in their training programs have been taught how to do prostate biopsies through the rectum. In contrast, there's another type of biopsy that's called transperineal. That's what I do. And the transperineal is, as it sounds, this goes through the area we call the perineum. Now, this is an area of skin that lies between the anus and the scrotal sac. And in contrast to the rectal wall, which you can't make sterile, we can sterilize this. It's just skin. Okay, so that makes for a big important issue, not having to worry about infections. Finally, if there's a tumor here or here in the front, there's nowhere that you cannot get to with a transperineal prostate biopsy. So that's, again, from the standpoint of geographical misses, and I think this gentleman asked specifically about that, you can miss it with the transrectal biopsy, but an experienced physician using transperineal should never miss a tumor.
Just sorry to interrupt you, but just looking at the map that you've drawn for the accuracy, it looks like the geographic distance between that top tumor right up there is just as far from the skin one as it is from the.
Right. That's because this needle is a set size, okay, and it's small. Okay, this needle can be any size. Okay, so there's no distance problem.
The other one's small because it's got to go through the rectum.
It's got to go through the rectum, and the rectal wall is fairly thick. Then it has a rectal fat plane that's got to go through just to get to the prostate. And I'm not, you know, I haven't shown you that, but there's a big thick layer that it also has to go through, you know, to get to the prostate. Whereas, and the needle is only, you know, typically no more than 2 centimeters, maybe a centimeter, depending on the probe and needle you're using. Whereas this needle could be any length. So there's no, you know, potential, you know, you could always still miss a prostate cancer, but you have a better shot with a transperineal. So as I said, from the standpoint of sterility, you got that. From the standpoint of not missing, you got that. Finally, or not finally, but you don't engage the big nerves of the rectal wall. And the nerves that are engaged are the ones in the prostate, but you engage those too with the rectal biopsies. Okay, but they're smaller nerves. So most men who've had those kinds of biopsies, transperineal prostatic biopsies, again, here I anesthetize you. We use conscious sedation, so it's not a general anesthetic. But when men wake up, they really don't feel much. A little bit, you know. We're actually, I'm in the midst of writing a paper right now, and on a scale of 0 to 10, you know, we will ask you, and most men will give it a 0 to 1, maybe a 2 in terms of pain. Whereas with the transrectal biopsies, most men will give you at least a 5 to 10. And finally, we're not engaging the big vessels in the rectal wall, the ones that circulate with your body's circulation. There are vessels in the prostate, but what happens is if there's any bleeding, and there can be, the blood typically meanders back to the urethra, and then it goes back into the bladder, and then you pee it out. So it's a closed loop. And there has never been a report, not a single one, of transperineal prostate biopsies resulting in dissemination of cancer cells elsewhere in the body. So those are the reasons why I prefer the transperineal approach. Um, we do use special instruments to guide our needles. So MRIs have come a long way. 15 years ago, the radiologist had a difficult time reading whether or not in determining if cancer was present in the prostate. And they learned back then that the reason that was the case was that, first of all, they were accustomed to looking at things that didn't move, like long bones, your femur, your hips, your shoulders, things like that. And they're basically static. The prostate moves all over the place. So they realized they had to increase the strength of their magnets. And so when I have a patient get an MRI, I make sure that the center that they're going to has the latest 3 Tesla magnet, because with that increased gain of Tesla, they can now take frozen frames and catch one where it's static, and because it's fast enough. And that's what the 3T does. Additionally, in the last, say, 5 to 8 years, so that, let me say, 10 to 15 years ago, when they got the higher Tesla magnet, they're now able to say, oh yeah, there's a cancer there, or something they forecast will be a cancer. Lately, what they're doing is they're taking all of the different parameters that they use to do an MRI and put them all together. And that's called multi-parametric MRI. And they use everything: diffusion weighting, blood supply, a lot of different parameters. And it's even now generated by AI. And what they say is, okay, you have a cancer, and we're going to predict it's this unaggressive or this aggressive, and they have a scorecard. It's called PIRADS, and it goes from 1 to 5. 5 being the most aggressive, 1 being the least aggressive. So that's what they do now, and they're pretty good. They'll typically say, this is a mass, and they'll say it's 1 centimeter, 1.5 centimeter, and it's consistent with a PIRADS 3 lesion, a PIRADS 4, a PIRADS 5. They've gotten really good so that most men having PIRADS 4 or 5 do have more aggressive prostate cancers upon biopsy. So MRIs have come a long way. Additionally, they fuse with our ultrasound technology. So even this probe in the rectum is an ultrasound. Okay, I use an ultrasound in the rectum as well, but we now have fusion technologies so that the MRI showed the cancer here or there, and we fuse with that MRI, and so we have XYZ coordinates to know exactly where we're going to biopsy. Now, I've come to find that's much better than not having a fusion MRI. However, if a person moves while they're getting the biopsy, those XYZ coordinates can be off. Okay, and so what we do here, and what I do here, is that I do something called a 3-dimensional color flow power Doppler ultrasound. It's a mouthful. We're one of the unique centers that do this in the country and the world. And it looks at the prostate in a different way. And I like to do it because it's complementary to the MRI. The beauty of it is it's in real time. So we're not only having the probe in the rectum, but that same probe is a special 3D Doppler probe that's looking at the prostate. And if you happen to move, as many men do, all is not lost, because we'll move with you. We can't bring an MRI to the ultrasound suite, okay? And that's the problem. But we can bring our 3D Doppler ultrasound to the ultrasound suite, and we do. So,
You use local anesthesia for your biopsy?
So what I do is there's a drug called propofol, and it's used, if any of you have had a colonoscopy, it's a milky white solution. And it basically, there's no, we don't have to worry about airway. We don't put a tube down your throat or anything like that. It's just similar to IV sedation. You just go to sleep. And again, if you've had a colonoscopy, it's fairly easy. And that puts the person to sleep so they don't feel what I'm doing. And then at the very end of the procedure, I do something that's I would say is unique. And I do a periprostatic block. So I use lidocaine with epinephrine, 2%, and I inject the paraprostatic nerves, which run alongside the prostate, the ones that cause pain after the procedure. And I think that's one of the main reasons why most of my men who've had biopsies feel very little, or when they wake up, I did a bunch yesterday and they didn't know what happened, and that's nice if you can have a painless biopsy, because in the old days, it could be pretty painful.
Last question, one more, last one, not related to that. Why does radiation, you get radiation treatment first, preclude future, or whatever, for surgery, if you have to get, whatever they call it, prostate?
Prostatectomy. That's a completely different question. Okay, so and this lady here has been asking, but I'll come back to that. Yes, ma'am.
If, I heard you correctly, going the traditional way through the rectum, like the wall, for a biopsy, if by chance there's already cancer in the rectal wall, is there studies about, I heard you mention, I think, that the rectal wall can disseminate to the body. Is there studies about the percentage of like how quickly that can happen?
So she's asking about what I said, the dissemination of cancer as a result of prostate biopsy. Now, the rectal wall does not have cancer in it, hopefully not. It's not a rectal cancer also, and that would be rare, but if it's a prostate cancer, it's just its proximity to the rectal wall and the fact that you got to go through the rectal wall and pull out the cancer, and because of the fact that there's big vessels in the rectal wall that you do engage, and when you do, it's possible that it spreads. But it's a very small number. And as I say, it's typically been reported as 1% or less. So that's, 1 in 100.
So if somebody does have rectal wall cancer, does that percentage change? Or if they already have it?
So she's asking about rectal wall cancer. Now that's a whole different ball of wax. It's an adenocarcinoma of the rectum. Okay. And it is true, just as I told you with prostate biopsies, when you're doing a rectal cancer biopsy, okay, that can spread rectal cancer. The percentages are still small, but they're higher than with prostate because you're already in the rectum. It's just a rectal phenomenon, and the rectal wall, is filled with big vessels. And it is the reason why rectal cancer is pretty early on, spread through the circulation, into liver, lungs, bones, and why rectal cancer is not as curable as something like prostate cancer. In the back?
I don't know if you were going to talk about this, and I don't know if it's too broad of a subject, but are there different classifications of treatments, right? So there's, radiation treatment. I guess there's variations on that. There's hormonal treatment, variations on that. And there's levels of severity of prostate cancer, or it's spread outside of the prostate, right? Is there any way that you can kind of condense or just talk across how you would normally go through a decision process to determine the severity of the cancer and what type of treatment would be appropriate for that?
Sure. So he's basically asking therapies related to prostate cancer and how we make that determination based on cancer. So let's go back to this drawing, and as I said, we'd probably be drawing the prostate now straight on. Okay, and if we look at it straight on, okay, it's actually shaped something like this. And so that while we often talk about it being like a small fruit or a walnut, it's actually like a heart. Okay, and it has a right and a left side to it, and the prostate urethra goes right down the center of it. Okay, and all urine must go through that prostate urethra. Up here, there's a really big muscle that we call the internal sphincter muscle, and it's actually part of the bladder, which is much bigger and up here, but it's the very bottom of the bladder, because the wall thins here, but it's the very bottom of the bladder, top of the prostate, has this big, thick muscle that we call the internal sphincter muscle, which is a control center for urination. It has a lot to do with your ability to pee. You know, when you got to go, this valve opens. When you want to close it, the sphincter closes. There's appendages here off the prostate, and we think of them as reservoirs. And the reason we do is because they're called seminal vesicles. So the prostate is pure and simply a sexual organ. It's a G-spot in men, has a lot to do with the orgasm, and then makes a lot of the ejaculate. And the two organs that make most of the ejaculate are the prostate and these seminal vesicles above the prostate. And all of the storage, however, is in these seminal vesicles. And then there are ejaculatory ducts which come down and join the prostate down here in an area we call the verumontanum. If you have urine here and you say go, the sphincter opens, the urination goes down the middle of the prostate urethra, and notice how it's straight in this diagram, it was curved in the other. And then it exits here, and this area right here is called the bulbar urethra. There's another group of sphincters here. They're very small compared to this one. These are called the external sphincters. And then this kind of winds around and becomes something we call a membranous urethra, and eventually the penile urethra, and that's how the flow goes. There is something we call the urogenital diaphragm, which sits over here. And then there's big nerves, arteries, and veins running alongside of the prostate, going to the penis. Okay, again, real sexual organ is the prostate. So with prostate cancers, they don't commonly begin in the center of the gland. They almost always begin in the areas that we call the peripheral zones. You just think of it as the periphery. And depending on how large the cancer is, denotes the stage. So for example, if there's a cancer here and it's localized to just this area, but you can feel it, you can see it, we ordinarily would say, well, it's visible, okay, it's feelable, so it's going to be a T2 lesion. Okay, so T2, we ordinarily would say in this case right here, again, not if that one's not there, just this one here, it's a T2A. Okay, all right. Then you say, well, yeah, this one's here, but what if it gets bigger and it incorporates more than 50% of this from here to here? Then it's a T2B. Okay, what if this one's here and you also identify one over there? It's a T2C. What if the cancer is coming on outside of the gland? That's a T3 lesion, T3A. What if the cancer's here and it goes into those seminal vesicles? That's a T3B. What if it invades, and I can't show you on this front side of it, but what if it invades behind it into the rectal wall? Or what if it invades